I am Dr. Dhiman Kahali. I am a senior interventional cardiologist and director Interventional Cardiology, Birla Heart Research Center, Kolkata. I want to tell that during the last 20-25 years, we are getting lots of patients, very young patients at their 20s and 30s who are coming with chest pain or in majority of the patients acute heart attack, acute myocardial infarction with hypotension and other complications. And in some cases, in about 40% of the cases of these young individuals, they are smokers. But in rest of the patients, 10% to 20% have some dyslipidemias, either high blood cholesterol with high LDL cholesterol, and a very few, say 1 in 400 or like that, homozygous familial hypercholesterolemia, and some has triglycerides high, normal cholesterol, LDL cholesterol almost high normal like that. So all these variations we get. And during our inquisitiveness, during the last few hours, we have found that some of these patients have hypothyroidism. We don't give much credential to the hypothyroid patients so far as cause of acute myocardial infarction is concerned. But we have seen a few patients where hypothyroidism is a major risk factor. And even in elderly patients or middle-aged patients who are not young, we get hypothyroidism as a major risk factor. And I think that it should be included in future as a major risk factor because many of the patients with coronary artery disease have significant hypothyroidism. And these patients don't develop collateral circulation. So, as I told about hypothyroidism, I am talking about the story of a young 22-year-old, lean and thin, vegetarian Gujarati patient who does regular asana, pranayam, etc. He came to me with severe chest pain, who had an extensive anterior wall MI, and his parents were crying, and the patient was tossing in the bed with severe chest pain. He was treated in another Kolkata hospital with all the amenities they had. He was thrombolized efficiently, but it was not successful thrombolysis. So the patient was having chest pain, his ejection fraction was 35%, and he was tachycardic, he was tachypneic, he was having mild LV dysfunction, he was having tachypnea with mild acute LVA. So in this situation, we took the patient to the cath lab, opened the huge LAD, which was occluded in its proximal third, and therefore so much of LV systolic dysfunction, and the patient became all right. And now he has a reasonable ejection fraction of 45% plus. So we have seen that this hypothyroidism is a very important risk factor. And last but not the least, overweight, indulgence to fast food, and very hectic lifestyle, overweight, obesity. These are some of the lifestyle modification, possible lifestyle modification candidates who had heart attacks because of their bad basal lifestyle situation. Anyhow, we therefore advise all of them to change the lifestyle so that in future they do very well. And a very few patients we have found that little lipoprotein A was very high in this group of patients, and they had actually thrombotic occlusion of the artery. One or two such patients had occlusion of a huge proximal LAD, proximal RCA, and then we did an angiogram, and immediately after the procedure, the angiogram which showed that it was 100% occluded, but there was no fixed blockade, and with angioplasty or thrombolysis, some cases it dissolved, some cases it did not dissolve. In PTCA, PCI, of course, all were treated well, and there was no residual lesion, at least angiographically visible lesion. We did not do IVUS in all these patients because of paucity of fund, but we saw there was no angiographically visible lesion. Even 5 to 10% lesions were absent in such patients. So the increased thrombogenicity due to high little lipoprotein A was responsible in such patients, and they gathered the LV systolic function well, and they recovered well, and their ejection fraction in many of the cases came to be 55 to 60% or even 65% with complete recovery of the LV systolic function, and they have done very well in future. So some of these patients presented with cardiogenic shock, also young patients with a huge proximal LAD occlusion and some disease in other arteries, and we did angioplasty in such patients because very young patients we don't want to send for bypass surgery. And another thing I want to tell, that below the age of 10 we have seen a very few patients with familial hypercholesterolemia where even stenting of left main coronary artery was required, and in one patient he required bypass surgery because of very diffuse nature of lesions. So two things are essential, that we should have a blood cholesterol and sugar estimation very early in one's life, that is 2 months or 3 months of age, and blood pressure measurement at an younger age, because blood pressure is also a precursor of hypertension, and those who have a hypertension, they develop it very early sometimes, childhood hypertension. So we can treat them properly and we can prevent the future complications. So it's becoming a menace in our country. This coronary artery disease is becoming rampant in the young individual. Some patients, they married and the girl is coming weeping, crying that what to do with her husband, and her husband's ventricle has become for 35% or 40% after massive heart attack, and many times, as found in the CREATE registry and Kerala registry, they come much late. Not even after 5 hours according to these two registries, but after 18 hours, 36 hours, after completely damaging the heart muscle. So preventive measures in such patients, proper advice, lifestyle modification measures, correction of high blood pressure, hyperlipidemia, cessation of smoking by continuous propaganda in print media and other medias is very much necessary to prevent these heart attacks or prevalence of coronary artery disease in these young patients. Thank you very much for your kind attention.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.